Assalamu alaikum. My name is Afra Ad-Dail. I'm a hematopathologist and the laboratory director at King Fahd Specialist Hospital in Dammam. It's my pleasure to be the moderator for the third and last session on day 2 of the Saudi Hematology Congress. And it is my pleasure to introduce Professor Armando Tripodi. Actually, when I read the CV of Professor Tripodi, I was really impressed, and I was really happy that I'm presenting him. He's a professor of clinical biochemistry at the Faculty of Medicine in Humanities University Milano, Italy. Besides his academic post, Dr. Tripodi is an established investigator at Angelo Bianchi and really, I'm sorry if I'm not saying it right, Bonomi Hemophilia and Thrombosis Center. He's actively involved in research focusing on different aspects of coagulation, including coagulation mechanisms, laboratory diagnosis of coagulation disorders, standardization and quality control of coagulation tests, as well as laboratory control of anticoagulant treatment. He served as a chair, co-chair, a president, and a member in many important committees and work groups, including the Scientific and Standardization Committee of ISTH, the Italian Society on Thrombosis and Hemostasis, and the Italian Federation for Thrombosis Centers. He served as editor or member of advisory boards in many prestigious journals, such as Journal of Thrombosis and Hemostasis and Hematologica. He is very active in publishing with 471 either original articles, reviews, or book chapters. And I'm summing it up because I don't want to take the time of the presentation by listing all the achievements of Professor Tripodi. So welcome, Professor. Today you're going to be talking to us about the updates in thrombin generation and bleeding and thrombosis. The mic is with you.
Thank you very much for your kind introduction. Good afternoon, ladies and gentlemen, wherever you are. I'm very pleased to be part of this faculty, and I wish to thank the organizers for this opportunity. During the time allotted to my presentation, I will talk on updates on thrombin generation in bleeding and thrombosis, but I also take the opportunity to address some of the issues which are concerned with another global coagulation test, which is viscoelastometry, or thromboelastometry, if you prefer. These are my disclosures. Before going into details of my presentation, let me briefly mention an history of the functional coagulation tests, which are based on thrombin generation and fibrin formation, which formed the basis for the history of hemostasis and thrombosis over the last century. The first test to be developed was the prothrombin time, which was developed in 1936 by Dr. Armando, who designed this test just to investigate jaundice in patients with liver disease. Actually, the prothrombin time is a misnomer because the name implies that the test is sensitive to prothrombin or factor 2. But we know now that a PT is sensitive to many coagulation factors. So PT is still a misnomer. The second device to be developed in 1948 was the first prototype of viscoelastometry. And then in 1951, the activated partial thromboplastin time was developed in order to help the research workers at that time that were purifying the first factor VIII concentrate to be used for the treatment of hemophilia. In 1952, the early prototype of thrombin generation was developed, and this was changed quite consistently in the 2000s, and it's now the current thrombin generation assay, which is used in many laboratories across the world. And now in 2022, all these assays are still alive, and during my presentation, I will try to give you some account of the merits and pitfalls. As you know, historically, PT and APTT were used to assess for thrombin generation and fibrin formation, and this test should be responsive to the balance of pro versus anticoagulants. But actually, we know, and I try to convince you in the next few minutes, that actually PT and APTT are unsuitable to represent the balance of pro versus anticoagulant. And in fact, there are some limitations of these two tests, which are listed here. First of all, PT and APTT, as you know, employ platelet-poor plasma, a medium which is quite different from the one which operates in vivo. Secondly, plasma in PT and APTT start to clot when only 5% of the total amount of thrombin is generated, and this means that the remaining 95% will be undetected by these two tests. And finally, PT and APTT are not equally responsive to the pro and anticoagulant factors, and this is another problem with these two tests. Essentially, PT and APTT are responsive to the procoagulant factors, and in fact, they are prolonged in hemophilia and allied disorders, and that's why these two tests are used for the laboratory diagnosis of these coagulopathies. But on the other hand, PT and APTT are much less responsive to the anticoagulant factors, and in fact, they are normal in patients with the deficiency of the natural occurring anticoagulants, for instance, protein C and antithrombin. The question now is why PT and APTT are not responsive to the anticoagulant factors. One of the reasons could be that protein C, which, as you know, is the main anticoagulant system operating in plasma, is not fully activated in the PT and APTT. In fact, you know very well that the protein C is activated by thrombin on the membrane of endothelial cells, where there are some receptors. One of the two receptors is the endothelial protein C receptor, which is the receptor for plasma protein C. The other receptor is thrombomodulin, which is the receptor for free thrombin, as you can see here. Now, because thrombomodulin and EPCR are very close one to the other, the substrate protein C and the enzyme thrombin comes to a close contact, and therefore protein C can be quickly activated and transformed into activated protein C. Then APC will form a complex with its plasmatic cofactor protein S, and eventually this complex is able to inactivate the activated forms of factor VIII and factor V, thus quenching thrombin generation. However, it should be realized that the plasma and reagents needed to perform PT and APTT do not contain thrombomodulin, because thrombomodulin is located on endothelial cells. So this is the evidence that PT and APTT do not represent the hemostasis which operate in vivo. As I mentioned before, in 1951, McFarlane and Biggs developed the first prototype of thrombin generation, which was in the year 2000 modified consistently by Professor Emker. And this modification is now the assay which is used in many laboratories across the world. Essentially, thrombin generation works on the basic concept, which is illustrated here. Once you activate the procoagulant factors by the addition to plasma of triggers, such as tissue factor phospholipids, thrombin generation starts to appear, as shown here by the ascending arm of the thrombin generation curve, and subsequently, the natural occurring anticoagulants are activated. They start to inhibit thrombin, and this is shown by the descending arm of the thrombin generation curve, as you can see here. Practically, thrombin generation is performed by exposing untreated plasma to some triggers, which are a small amount of tissue factor phospholipid and calcium chloride. These are relatively small amounts because you want to mimic what happens in vivo. Once the coagulation is activated, thrombin starts to appear, and this is continuously monitored by a fluorogenic substrate. Optical density is recorded, and from the optical density, the system is able to automatically trace a thrombin generation curve. This is a typical thrombogram, a thrombin generation curve, if you prefer, which can be obtained in a plasma from an healthy subject. It is completely represented by some parameters. Among them, the most important are the lag time, which is the time needed from the ignition of coagulation to the first appearance of thrombin. Another interesting parameter is the peak height, the time to reach the peak, and finally, the area under the curve, also called endogenous thrombin potential, or ETP. By definition, the ETP is the net amount of thrombin which can be generated in a given plasma under the driving forces of procoagulants as opposed by the anticoagulants. Thrombin generation can be used essentially to investigate both hypocoagulability but also hypercoagulability. As you see in the slides, the prolonged lag time, low peak, long time to peak, low ETP denotes hypocoagulability and vice versa. So this procedure is really very interesting because it gives you the opportunity to investigate both hypo and hypercoagulability. Now, there are many commercial kits which are available for thrombin generation on the market. They may be different in terms of composition and procedure, and I would like just to give you some information about the desirable features for a good thrombin generation procedure. This procedure should have relatively low tissue factor concentration because we want to mimic the conditions operating in vivo. I would also like to have a system capable of including platelet-rich plasma if it's possible, because in some occasions we want to investigate the contribution of platelets in thrombin generation. And also I would like to have the possibility of adding exogenous endothelial cells activators in the system, such as thrombomodulin and or glycosaminoglycans. And finally, I would prefer having a fluorogenic substrate rather than a chromogenic substrate. Now, the second part of my presentation, I give you some example on the practical application of thrombin generation. I selected some of them, but if you are interested, we can go ahead during the discussion and try to see if there are some other clinical situation where thrombin generation may be useful. Let's start with the elucidation of mechanism regulating thrombogenesis. There are a lot of papers published in the literature on this topic. I've just chosen one of this situation, which in my opinion was really very important. I'm talking about this paper we published some years ago, in which we showed evidence of normal thrombin generation in patients with cirrhosis, despite the fact that this patient may have abnormal conventional coagulation tests, such as the PT and APTT. And in fact, when we investigated the platelet-free plasma for thrombin generation in this patient, in the absence of thrombomodulin, we found that the cirrhotic patient generated much less thrombin than the control population, as you can see here. But this was completely expected, as it reflects the partial deficiency of the procoagulants in cirrhotic patients, which are not counteracted by the concomitant deficiency of the natural occurring anticoagulants, namely protein C, which could not be fully activated because there is no thrombomodulin in the system. And in fact, when we repeated the experiment by adding thrombomodulin, as you can see, the control population generated much less thrombin, and this is expected because in this condition you fully activate protein C. Also, the cirrhotic patient generated less thrombin, but the difference between control and cirrhotics here was much less, as you can see, so that there was no longer statistically significant difference in the thrombin generation between control and cirrhotic patients when thrombomodulin had been added into the system. Now, we interpreted this result as an evidence that there was a rebalanced coagulation in this patient when coagulation has been investigated by including thrombomodulin in the system. So, in summary, it seems that this experiment told us that plasma coagulation is not abnormal in cirrhosis, as it was previously, thought. Provided, obviously, that hemostasis or coagulation is investigated with global tests, which reflect the function of both the pro and anticoagulants. And you may remember that the PT and APTT are not able to do so. So these findings supported the concept of balanced hemostasis, which changed our, thinking about the coagulopathy of liver cirrhosis. And most importantly, this finding questioned two important practical aspects: the usefulness of traditional coagulation tests in assessing hemorrhagic risk. I'm alluding to the PT and APTT, which are still used to assess the hemorrhagic risk in this patient, but these are not of value. And also the use of procoagulant agents to correct the coagulopathy, which is a common practice, for instance, before surgery or invasive procedure in these patients. I think that the balance of hemostasis can be best depicted by this cartoon, in which you see that the balance of hemostasis in healthy subjects is very stable, simply because healthy subjects have an excess of pro and anticoagulants, which stabilize the system. But the situation is quite different in cirrhosis, where there is a relative deficiency of pro and anticoagulants, and therefore the balance of hemostasis is less stable and may tip towards hemorrhage or thrombosis, depending on the prevailing risk factor to which the patients are exposed during their life. Let's move now to a second example, the use of thrombin generation for the management of congenital coagulation disorders undergoing surgery. Some months ago, we investigated global coagulation tests to assess the value of the presurgical treatment in a patient with the congenital factor 11 deficiency and an inhibitor. This patient has to undergo surgery, and we didn't know very well on how to treat this patient during surgery. From the literature, we saw that recombinant 7A could be of value in this patient, but we didn't know exactly the dosage to be used. We know, obviously, that for hemophilia patient, the dosage was 90 micrograms per kilogram, but we felt that for this patient, probably it would have been too much. So we collected blood from this patient. This blood was spiked with increasing amount in vitro of recombinant 7A, starting from 0 to 90 microgram per kilogram body weight. And on these samples, we measured thrombin generation. You see here the results. As you see here on the bottom graph, the solid line represents the baseline endogenous thrombin potential, which was relatively low, is lower than the lower limit of the normal range. But you see from the broken lines here that when we added as little as 15 microgram per kilogram, you see that the endogenous thrombin potential was completely restored. So we decided to treat the patient during surgery with 15 microgram per kilogram body weight. Surgery was successful. The patient didn't experience a hemorrhagic event or thrombotic event. So with this experiment, we spared money because we used only 15 microgram per kilogram rather than 90 microgram per kilogram. But also we spared some thrombotic risk to this patient because, as you know, recombinant 7A infusion carried the risk of thrombotic events. So this is a good example on how you could use in some situations a thrombin generation to help resolve some treatment issues. What about monitoring hemophilia treatment with bypassing agents? This is another area where thrombin generation is really crucial, is very important. As you are aware, APCC and recombinant 7A are the conventional bypassing agents used to treat hemophilia patients with inhibitor. However, they achieve effective hemostasis without modifying plasma factor 8 or 9, and therefore the measurement of factor 8 or factor 9 to monitor these patients is quite useless because they do not reflect their hemostatic activity. So we have to use alternative global assays to monitor these bypassing agents, and the candidate assays are thrombin generation, which, as I mentioned, can be performed in platelet-poor, platelet-rich plasma, and also thrombelastometry, which is performed in whole blood. This is a paper I selected for you in the literature as a monitoring bypassing agent therapy. This was a prospective crossover study which compared thrombelastometry and thrombin generation. Let's look at the results. These are the results for thrombin generation. Particularly, you see here the lag time, one of the parameters of coagulation, and you see that for both concentrate, for both the bypassing agent, APCC, and recombinant 7A, just 50 minutes after starting the infusion, the lag time started to be considerably decreased, as you can see here, in all the patients which were investigated. And the same happens for the mean ETP, the mean endogenous thrombin potential. Here, obviously, it is the reverse. After 15 minutes from the infusion, you see that the ETP started to considerably increase. These results tell us that thrombin generation is responsive to the procoagulant effect of both bypassing agent APCC and recombinant 7A. So this procedure could be used just to monitor the treatment of these patients. What about thrombelastometry? I'm sure you are familiar with this procedure. It is completely characterized by some parameters. The most important are the clotting time, the clot formation time, which gives you information about the velocity of clot formation, and finally, the MCF, which gives you information about the firmness of a clot formation. Let's look at the results. As you can see here, the mean clotting time for both APCC and recombinant 7A was consistently decreased in all patients 15 minutes after the infusion, after starting the infusion. And also, the mean MCF was increased consistently, as you can see here, after 15 minutes from the infusion. So again, even thrombelastometry, like thrombin generation, is responsive to the procoagulant effect of both APCC and recombinant 7A. Another good example is monitoring hemophilia prophylaxis with the coagulation factors concentrate. This paper I selected was monitoring the prophylaxis by using a global hemostasis assay. And as you can see here, both ETP, endogenous thrombin potential, and thrombin peak on the bottom here started to consistently increase during the infusion, and after, I would say, half an hour from the infusion, they started to be consistently higher than the baseline. So even in these conditions, thrombin generation is really useful to monitor these patients. Risk assessment of recurrent VTE. This is a crucial issue because, as you know, after the first event of venous thromboembolism, many patients will sooner or later develop recurrent venous thromboembolism. So it is important to assess the risk of recurrent VTE, and we wondered for many years if there were some laboratory tests able to detect this risk. Some years ago, we published this paper in which we showed that high thrombin generation, particularly when measured in the presence of thrombomodulin, is associated with an increased risk of recurrent venous thromboembolism. Months later, another group of research workers independently confirmed our results, and also they added a new information. The information is that elevated D dimer together with thrombin generation is a risk factor for recurrent venous thromboembolism. Now, you know very well that D-dimer is much simpler to be carried out than thrombin generation, and this is why many laboratories in the world at the moment use D-dimer to assess the risk of recurrent venous thromboembolism. However, Dr. A. Kinger and co-workers investigated the prediction of recurrent VTE by measuring both ATP and D-dimer. As you can see here, they confirmed our results that patients with an ATP higher than 100% had an increased risk of venous thromboembolism than those with an ATP lower than 100%. But also, they investigated this patient for both ETP and D-dimer, and they found that when the ETP and D-dimer are concomitantly increased, the patient have an increased risk of venous thromboembolism more than those patients detected by either test used in isolation. So it means that probably if we combine the measurement of ETP and D-dimer, I think that the robustness of the prediction is much higher. Finally, I would like to convey with you the last example, which can be used for thrombin generation, is the risk assessment of cardiovascular diseases. Some months ago, Dr. Van Parijden and co-workers published, investigated thrombin generation in cardiovascular disease and mortality, and reported results from the Gothenburg health study that enrolled more than 5,000 patients in this study. So it's really a very robust study. They found that high ETP in this patient is associated with increased mortality, as shown here by the red line on the bottom of this graph. So it means that probably even in a population-based case control study like this, probably endogenous thrombin potential may be useful to detect some sign of hypercoagulability, which sooner or later may lead the patient to have thrombotic event or cardiovascular disease in general. So from my personal experience and from the literature, I can conclude that thrombin generation, but also viscoelastometry, are better suited than the conventional tests. I'm alluding to PT and APTT, but also to the measurement of the individual coagulation factors to represent in vivo coagulation. And obviously, further research is needed just to link thrombin generation with the clinical outcomes, and also to assess the value of viscoelastometry algorithms, which are currently based on expert opinion, but we want to have this algorithm validated in randomized clinical trials. I stop here and thank you very much for your attention.